Good morning, everyone. It is my honor to introduce Dr. Lois Choi-Kain, who is currently the director of the Gunderson Personality Disorders Institute, an internationally recognized center for training for empirically supported treatments for borderline personality disorder and research on outcomes, as well as the social cognitive mechanisms targeted in these interventions. She is also an associate professor of psychiatry at Harvard Medical School. Her research training began as a postdoctoral fellow under the supervision of John Gunderson, MD. As PI, co-investigator, and collaborator on several NIMH and donor-funded grants, she participated in studies of neuropsychological and social cognitive correlates of BPD and attachment, in addition to other biologically centered aspects of BPD, including heritability, family aggregation, and hypothalamic pituitary adrenal axis hyperactivity. After 3 years of research training, Dr. Choi-Kain developed an intensive residential treatment program, the Gunderson Residence, combining various empirically supported therapies with the milieu setting, emphasizing rehabilitation of social and occupational functioning. She also developed a training institute offering CME-accredited trainings in MBT, DBT, DBT-PTSD, and transference-focused psychotherapy and good psychiatric management. Dr. Choi-Kain has unique expertise regarding these many approaches, enabling her to bring together their common factors in a generic form of more widely available treatment. Dr. Choi-Kain has also written extensively about the problems of access to care and scalability of our armamentarium of BPD treatments. She has written 3 books on various applications of Gunderson's good psychiatric management as a public health scalable solution to the demand and supply gap in BPD treatments. Please welcome Dr. Choi-Kain.
Thank you for that introduction, and thank you for the invitation to come speak to you today on this kind of what I consider the last day of summer. Maybe that doesn't mean as much to you out in LA, but here in the Northeast, we're trying to savor it. But thank you for being here today with this interest in how to expand care for BPD in usual settings. So what I'm going to do is share my screen and give you a real update on the current evidence base for treatments for BPD. And hopefully this will change your mind a little bit about what you can actually do in helping people with this disorder when they come to any clinical setting that you are doing your work in. So to just start with conflicts of interest, I do receive royalties from the publication of GPM books. I consult with Tetricus, and any discussion of medications will be off-label because there are no on-label medications for BPD. So like most of you may understand, there has been tremendous progress in the understanding and treatment of borderline personality disorder. You may recognize 2 figures here, Marsha Linehan and John Gunderson, who were 2 human beings that revolutionized our attitudes about borderline personality disorder. There was once a time that people did not think this group of individuals was treatable. In fact, the first mention of the term borderline in the psychiatric literature was in 1938 by psychoanalyst Adolf Stern, who first used the term to delineate a group of people who were on the borderline between the psychotic group of people who showed up to care in most usual care settings, as well as the psychoneurotic group. So it was a group that was distinguished by some level of severity in their psychiatric presentation, but also some pockets of functionality. And this group of patients, in response to prevailing treatments that were thought to work at the time, had what were called negative therapeutic reactions. Now, at the time, it wasn't really well understood that part of their interpersonal hypersensitivity that was driving these reactions would be the focus of treatment in more modern variants of intervention. But towards a path of improving our understanding and treatments of BPD was the important incorporation of the diagnostic category into the DSM-3. This happened in 1980. And John Gunderson was actually an important figure in this development because he had synthesized the extant clinical, theoretical, mostly analytic literature into an approach to codify diagnostic features. And then he started doing research on those features. Now, the background of John Gunderson's work was he was at the NIMH in the 1970s, and he had started his career studying the efficacy of psychotherapy for schizophrenic patients. Of course, his work with collaborators led to the understanding that psychotherapy alone was not a definitive treatment for schizophrenia. And in the process of doing that work, he realized there was this other group of patients that seemed to be different. And he dedicated his entire career to enhancing our field's understanding of these individuals. Interestingly, in the course of researching for this very lecture, I learned that this diagnosis never even entered the ICD until 11, which I'll talk about. But the ICD-10 included an entity that was meant to kind of destigmatize BPD by calling it emotionally unstable personality disorder. I don't know if it's me personally, but I'm not sure that's a less kind of problematic phrase, but it has been adopted in Europe where the ICD is used. But in this era, there was still tremendous misunderstanding and negativity about the utility of the BPD diagnosis. Famously, Hagop Akiskal, a mood disorder researcher, said that borderline was simply an adjective in search of a noun. And George Vaillant, who's a very well-respected researcher, said that there was wisdom in never calling a patient borderline. But this all changed in 1991. Amidst some of this conversation, Marshall Linehan thought, you know what? People are wrong about this. There are a group of patients who are highly suicidal, who are not responding to treatment, but maybe something different needs to be done. And as you all may know about she did famously come out in the New York Times with her own story of having been a chronic inpatient with suicidal behavior. Fueled by this personal experience of treatment that does not work for suicidal individuals and a vast knowledge of both the psychodynamic and CBT literature, she developed DBT and was the first to test it, which was shown to be more effective than usual CBT approaches to helping these patients. So this started a new branching point in the history of evidence-based treatments when some of these newly emerging treatments, such as dialectical behavioral therapy, mentalization-based treatment, and something called STEPS. It's system training for emotional predictability and problem solving. These treatments were the first to kind of enter the literature and shown to be more effective than treatment as usual. Now, this was the 90s when treatment as usual for BPD was informed by thoughts like those kind of expressed by George Vaillant, that there wasn't wisdom in calling people borderline. So there was very underdeveloped care for BPD. And we know from these trials that those with BPD weren't responding to those treatments. So the bar of superiority was not very high. But the methodology at this time was as probably sophisticated the fashion at the time. And the treatment trials have really improved in their rigor since then. So in the 2000s, these studies improved by having enhanced comparators. So DBT was administered in early trials by experts in treating suicidal patients, Marshall Linehan being one of them. So she put DBT more rigorously up against treatment by community experts. Similarly, transference-focused psychotherapy went up against experts by community psychiatrists in Germany. Schema-focused therapy went up against TFP, and then TFP went up against DBT and supportive therapy. And in this wave of research, a lot of those studies basically said these treatments aren't as different as these treatments are from treatment as usual. But DBT still had an edge over community experts in terms of reducing suicidality. The same was true about TFP and DBT versus supportive therapy. There were virtually fewer differences between specialist treatments for BPD and other specialist treatments. And I'll say more about that. And really, the treatment literature actually comes to a halt before COVID. There hasn't been a ton of monumental findings since 2018, when a lot of these treatments were going against even better comparators, manualized, generalized approaches to treating BPD, so that the comparison arm was still delivered in a way that was tailored to treat the main diagnostic problem. And in these treatments, there were virtually no differences. I'll talk about DBT versus general psychiatric management, but there were no differences in well-employed DBT and a much less intensive variant administered by people who liked treating people with this condition. Similarly, in the UK, MBT went up against structured clinical management, which is also manualized with fewer differences, and so on. So this opened the door to the proliferation of evidence-based treatments and guidelines for the treatment of borderline personality disorder across the world. In 2001, we had the first guidelines published for BPD ahead of a lot of this literature being published. And we just went through committee-based development of new guidelines that are to be voted on this fall. And like I said, the ICD-11 was the first variant to actually put BPD in, and that was actually a compromise in the giant raging controversy between the categoricalists and the dimensional people in the world of personality disorder diagnosis. Even though the ICD-11 uses a more dimensional diagnosis of personality disorder, they did put in there a BPD specifier, since there is such a robust and critical literature on BPD itself compared to the other disorders, for which there is no proven evidence-based treatment. Now, these new guidelines from the APA include 3 directives that are recommended that all clinicians in the mental health profession can use in some way, shape, or form. This includes, at first, initial assessment that includes a BPD diagnosis routinely. This is a diagnosis that's common in both the general population and even more so in mental health clinical settings. So the likelihood that patients may meet this diagnosis is fairly high. Collaborative diagnosis, personalization, and psychoeducation should be routine. And if you need help with assessment, there are these measures that can be used. Then the recommendations indicate that psychosocial or psychotherapeutic treatments tailored to the disorder are the ones that are basically the first line interventions. Treatment should focus on core features of the disorder, including interpersonal sensitivity, emotion dysregulation, and identity issues. This is in the context of the literature that says that there is no psychotropic medication that is effective for the treatment of this disorder and is simply adjunctive to psychotherapy for those with BPD. Many, if not most, people with BPD will have co-occurring disorders for which psychopharmacologic treatment may be indicated, but has never been strong evidence for the use of any agent from clinical trials. Now, in reviewing the psychotherapy literature, I'm going to show you the kind of study that has been undertaken to inform these guidelines. Part of what happened in the formation of these guidelines is we met as a committee over many, many months. It was a very impressive process, I have to say. And as a psychiatrist, working for the APA on any committee is a very gratifying experience from my point of view. But what this was based on was actually a study that was conducted by the Research Triangle Institute, where they did a review of all the psychotherapy studies and all the psychopharmacology studies in the literature that use the DSM-4 or 5 as a diagnostic method for those who have BPD who are 13 and older. So in looking at the psychotherapy research for BPD, these kind of jokes about general psychotherapy limitations do apply. And at the end of the day, this first kind of message that everything works equally well, we should stop fighting, is actually a major message. This meta-analysis that was done by Christea, not by the Research Triangle Institute, was published in JAMA. And she found that even though psychotherapies tailored for BPD work better than treatment as usual, they had small to moderate effect sizes, and there was no kind of contribution of treatment duration or intensity to the outcomes. So longer treatments or more intensive treatments were not necessarily better, and the treatments by specialists did not necessarily retain patients better than the comparators. Lastly, there were no differences between these types of psychotherapies, even though all of them have argued that theirs is the best. And the main issue is that if the control group is balanced for the involvement of the experts, with a manualized protocol, they found no differences across these limited studies. There are these other limitations that apply across psychotherapy studies. Most importantly, that there's an implementation gap, which means that these intensive protocols that are studied in the rarefied context of randomized controlled trials don't translate well into the real world context of clinical care. So now we know there are these other limitations of evidence-based treatments. First of all, I don't have to explain very much about the limited access to care. All of you who have tried to refer a patient to any of these specialist treatments probably have found limitations in the fact that most of them are self-pay, or they have long waiting lists, or both. And that's even like in a major metropolitan area like LA. We at McLean, when we have to refer someone to LA, they're like two people we call, Robin Kissel and Carl Fleischer. And that is not enough for a town as big as Los Angeles. But we also did an analysis in this study of the access problem about generalist care. So if we took all the mental health professionals in a given country and divided the number of people seeking care with BPD, estimated based on treatment-seeking populations, over that supply of generalist care, each clinician in the most well-resourced countries like ours would only have to see 4 patients with BPD. So this generalist approach might be a better solution. And of course, when something is less specialized, you have to aim for good enough rather than the best. Because even in the best of treatments, there are high dropout rates and high non-response rates. We did a study of dropouts like many other groups, and the dropout rate was about a quarter. That's actually consistent across different meta-analyses. It's a little higher in RCTs, and we adjusted for bias, which brought this up to 1/3. And if you've actually worked in a treatment setting with people who have BPD that's specialized, this probably reflects a pretty accurate dropout rate. Now, there's also the issue of non-response. In this paper done in Australia, they reviewed studies and they found that if you looked at the response rate, people who responded to the treatment versus not, rather than an average mean response, they found that almost half of the participants in these published studies did not respond to these treatments. And that was not different across treatment types. Lastly, there was this more recent study that was published by Kupcher et al. I probably mispronounced that, but this is a very important study because it was the first one to compare response rates among different major mental disorders. So they took psychotherapies for the that were the first-line treatment for a number of different disorders. You see them on the right of this graph. And then they charted the response rate of a 50% reduction in symptoms as the classifier for whether or not the patient was responding. Now, what they found overall is that the response rate to psychotherapy, that is over 50% reduction in symptoms, was actually low across all disorders. So you see that like a 0.42 response rate was the best of them all, and that was for major depression. And you see that is much higher than the response rate of the control. But if you go all the way down to BPD, which is at the very end, you see that it has actually the lowest response rate as well as the lowest difference from the control. And that's something that I want you to keep in mind. If you look at this data in more granular detail, I'm sorry for how small this looks, but this is how I could do it. You look at the number of studies they included, and actually the BPD literature is not actually that bad. It's on the same level in terms of the number of studies and the number of participants as OCD. But it's not nearly as many studies or participants as major depression. Now, if you look at this bottom below, this line below at the very end, I want you to pay attention to the number of sessions these treatments involved. And the BPD arm only included DBT treatments because they were the ones that fulfilled the methodologic inclusion criteria. But this is a intervention that typically had, on average, 53 sessions compared to about 10 at most for the other disorders, 11 for GAD and 12 for OCD. Furthermore, a little bit of DBT does not go a long way. This is a very interesting study that I learned about when I was doing grand rounds at the University of Washington. This was done out there in Washington by the Kaiser Permanente Research Group. What they did across a number of large healthcare systems is a randomized controlled trial using individuals within that healthcare system that had frequent suicidal ideation. So they didn't necessarily have the diagnosis of BPD. But what they tried to do is randomize people either into treatment as usual in that care system or a care management approach that enhanced that care based on the collaborative care model. They did regular screenings using this Columbia screening instrument for suicidality, as well as enhancing the navigation of the care pathway. And the third condition was a DBT light condition, where they did videos for these 4 types of DBT skills, as well as some online coaching to use these skills by trained master's level clinicians, and that was all sent through the AHR. Now, what they then did was try to chart the kind of return to either fatal or non-fatal self-harm. What they found was actually the collaborative care management approach did not show convincing superiority over treatment as usual, but light DBT was associated with a faster return to self-harm, and that's shown in this group. So what's difficult about DBT, even though it's a wonderful, comprehensive psychotherapeutic approach that has revolutionized psychotherapy at large, nobody knows really the dosage that's optimal and effective. So these treatments that we've developed for the treatment of BPD are intensive and comprehensive in their packaging, but nobody knows what is the optimal dosage, what are the effective ingredients, and these treatments are bulky, so they tend to not be one size fits all. They certainly don't fit most levels of care where most psychiatric professionals get their training. Or are exposed to the broadest range of types of psychopathology. And we know that these treatments are situated as outpatient interventions. But in areas like primary care, inpatient units, and emergency rooms with patients presenting with suicidal ideation, people with BPD represent a large proportion of that group of presenting individuals. So there's a lot of room to provide a scaled approach to responding to patients who seek care for BPD, and that's similar across adult and adolescent populations. We've thought for a long time inpatient hospitalization is not an effective treatment for BPD, and yet most people with BPD have been hospitalized at some point in time. And I think we need to take a more moderated view that any patient who is suicidal should have the right to be hospitalized to seek support in a time of need. But using that hospitalization effectively is something that requires guidance. And the well-known evidence-based treatments are not scalable to 2-week stays. At baseline, in longitudinal studies, about 80% of those with BPD will report any psychiatric hospitalization. This is higher than those with other personality disorders. And at baseline, a majority of people with BPD will report multiple hospitalizations. And even when they remit, some proportion of them will still have hospitalizations. And when they are hospitalized, among inpatients with suicide risk, about 40 to 50% may have BPD, and most of those individuals are misdiagnosed. These are patients who are younger, have more psychiatric medications, even though no medication is indicated. They tend to be more chronically depressed, and they're more likely to be readmitted. Now, this can't be all we offer to people at the front lines of care, because while people are in pain, they may go to the hospital or the emergency room to seek support. But this becomes a holding zone where they don't get any definitive interventions for the cause of their suicidality. So that brings us to question whether a reliance on these intensive evidence-based psychotherapies is sustainable. Now, back to this Research Triangle Institute group. They've published these 2 papers. This one just came out in the Journal of Consulting and Clinical Psychology, a very high impact journal. And what they did was really establish new standards on what's good enough. And this is what the APA guidelines is on. So the current state of the literature, as summarized by this paper, says that the guidelines that are out there internationally are not often based on systematic review of the empirical literature on treatments for BPD. The guidelines we've been operating on since 2001 came out before a lot of the treatment trials. So it was long overdue to do a systematic analysis of the studies out there, and they use different standards than have been used in other guidelines. So you'll see in the 4th bullet point, the inclusion criteria included adolescents, that is allowed by the DSM, and has been through the DSM-3 actually. It had to involve a commonly utilized therapy, have a comparison to either treatment as usual or another psychotherapy, evaluate BPD relevant outcomes. And this included both randomized and non-randomized or controlled designs, because that's what's out there in the community as well. They applied the grade approach to evaluating this literature. So this literature is pretty small, and it included 25 studies, which reported on 20 randomized controlled trials and a few non-randomized cohort-based studies. And 17 of these studies compared these 9 psychotherapies to treatment as usual. What was excluded are people with other disorders, sometimes even common disorders, such as major depression, substance use disorder, and bipolar disorder, and mostly excluded those with schizophrenia. And how generalizable this is lies in the constitution of these samples. It's mostly women, about 80% women. There's sometimes males in there, but I don't think we even know if these treatments generalize to be effective in genders other than those that are female identified. And of course, these are mostly white, almost exclusively North American and Western European populations. I think there's a couple studies from Australia and I think a multi-site study that involve like another part of Europe. So the state of knowledge, according to this study, is that there is very low to low certainty of evidence across trials with a high risk of bias in most of the reports that were published by the treatment developers. The translation of superiority, once it gets to a group independent of the developer, goes down. Overall, both treatment as usual and the 9 included psychotherapies were shown to reduce symptoms of BPD. But there was moderate to low certainty of evidence that any of these specific treatments were more effective than treatment as usual. What about the discrete treatments? DBT was the best represented in the literature. Almost half the trials included studies using DBT, but there was still low strength of evidence for DBT. That's why we didn't advocate for DBT in the APA guidelines. And there were mixed findings that some trials actually found treatment as usual to be equivalent to DBT. So while DBT is a dominant and popular treatment as a first line, it has low evidence of superiority over other choices. Now, mentalization-based treatment, there's a huge center called the Mentalizing Institute there in Los Angeles by your own Robin Kissel. So this is an approach that's well known. It's more well represented in Europe than it is in the United States. But this is, even though it's the second most popular, there were only 3 studies that met criteria for this review, and there was inconsistent evidence in adult and adolescent samples. So evidence did not support the use of MBT for adolescents because there was a large trial published in Scandinavia that did not show superiority of MBT groups for adolescents with BPD. And the evidence does not support recommending MBT over other psychotherapies for the treatment of BPD. Now, ironically, this not well-known treatment called systems training for emotional predictability and problem solving, it's like a kind of simplified version of DBT, and it was administered first at the University of Iowa, where they thought this Zen Buddhism stuff would turn off a lot of the people in the community. They're not as open-minded, apparently, as people in a Zen culture like LA, probably, but actually simplifying DBT seems to work. This is the approach that's most adaptive, flexible, and potentially scalable, but is poorly disseminated for some reason. It was tested as an adjunct to treatment as usual and only included 20 group sessions of skills training. And there's actually the best evidence for the certainty of steps being superior to treatment as usual. But there's insufficient evidence that it's better than any other particular specified psychotherapy for BPD. Now, here is the data on generalist treatments for BPD. This is an emerging literature, and it was almost a discovery by accident when DBT and MBT wanted to have a better comparator. These trials showed very minor to no differences in almost any outcome between these specialist well-known approaches and a manualized, not annualized, generalist one like GPM or SCM. There are others in the literature. But this is low certainty because there were only a few head-to-head studies that employed these treatments. And what the authors of this paper said is that our findings suggest that generalized psychotherapies may be as effective as intensive specialized BPD treatments. And actually, in clinical practice, most patients with BPD are often treated with medication alone or in conjunction with psychotherapy. So those patients who are already in some sort of treatment with a non-specialist might benefit from these generalized psychotherapies. So this brings me to a discussion of GPM, general, which kind of exploits common factors in psychotherapy that are shared among psychotherapies in general and in particular for BPD that are effective. It may not be superior, but it's good enough, or at least not statistically significantly different than well-known effective treatments such as DBT. It's psychiatric not only because people of a certain discipline can employ it, but it's not necessarily an intensive psychotherapy. So it's a mental health intervention that's psychosocial and scalable to different care delivery methods. So, like I said, this is a generalist approach that recruits kind of a number of factors that contribute to the success of psychotherapy that we can all make use of by doing what's generally good for patients. If you look at the common factors contributing to the outcomes of psychotherapy, we see that actually placebo, hope, and expectancy factors contribute as much to the outcome as the type of therapy. But these combine to be equivalent to the impact of the patient-therapist relationship. So whatever approach you're using should stabilize the patient-therapist relationship so that it's durable despite the instabilities that are characteristic of borderline personality disorder. And then a lot of it comes from other factors that have to do with the psychopathology itself, that is the severity of the psychopathology. And unsurprisingly, a lot of those other factors have to do with the social economic context the patient is in. We could do patients a lot of good by helping them get basic needs met. That might work better than some psychotherapies in some cases. So if we focus on these common features, which include a well-specified formulation of BPD, highly structured treatment with a selective focus, clear aims, and consistent procedures, and a way of maintaining a strong and durable alliance, we can do a good job with these patients. And that should be true of any disorder. So this brings us to this GPM model, which was developed based on John Gunderson's clinical guide, which the first edition came out in 1984. This was an edition he wrote with Paul Links. And actually what happened was when Shelley McMahon was running that 2009 published trial, she wanted DBT to go up against a decent comparator. And Paul Links, who is the head of the GPM arm, he used John Gunderson's book plus the existing APA guidelines to develop an approach that didn't involve any DBT skills. So this was delivered by psychiatrists mostly, but some other disciplines who had experience and liked working with these patients, matched with DBT therapists on the other arm who were highly trained, delivering 3 times as much treatment in general to these patients. And surprisingly, the results were good news to us, but maybe not what the DBT world wanted to see. In terms of DBT's specialty of reducing self-injurious behavior, these approaches were not statistically significantly different. And this is shocking because of how much attention DBT pays to these problems. This is not in general psychiatric management because the goals and focus are collaboratively selected. And when you look at the 2-year follow-up of these treatments, we find the same result of no statistically significant differences. You see here the DBT is in the blue, GPM is in the red. And you see on the left upper corner that in terms of BPD symptoms, they both are very effective at the end of treatment. They see a huge reduction in BPD symptoms, and that is sustained over time. But if you look at these other metrics, what's really interesting, I think, and this is just kind of like an impressionistic interpretation, is that the red line seems to be straighter and have less of an elbow when treatment ends. Maybe I'm just reading into that for personal gain, but that's what I think. And I think there's actually a huge placebo response. People with BPD are interpersonally sensitive, they like support, and they respond to it non-generically. And if we could prescribe more placebos, we'd be better off without causing side effects or detrimental problems like weight gain for these patients. And it would probably be a lot cheaper. Lamotrigine was heralded as an effective treatment at a time when I started in this work, and I used to teach people that this was an agent that was effective. But then Mike Crawford and his group came out with this study about the clinical effectiveness of lamotrigine. And it's not that it wasn't effective, it was that it didn't separate from placebo. If you look at this graph, both lamotrigine and placebo did pretty well in reducing BPD symptoms. And if you see it plateaus at 12-week time, if you superimpose the graph from the McMain study, the amount of differential gain of DBT and GPM at 12 months is about maybe like 4 or 5 points on the ZAM BPD. So there's something about the delivery of good psychiatric management, people evaluating these patients and checking in on their symptoms, that can be effective. So if you diagnose people with BPD, like they did in this lamotrigine study, and provide some psychoeducation about what the symptoms are, patients learn about the symptoms by being evaluated. Knowing that this is a common disorder, there are all these people in this trial because we're trying to learn how to intervene effectively. You are not alone. Many people have this condition and many people are trying to treat it effectively. And if you look at the longitudinal course, even without these treatments, people do get better symptomatically over time. And there are biological contributions that kind of say to patients more objectively, this is not necessarily your fault, but you do have to manage your vulnerabilities. A lot of people are phobic that diagnosis will be harmful, but the diagnosis of BPD, having BPD, is more detrimental to the person than just hearing the diagnosis. There is no evidence that delivery of the diagnosis is harmful. In fact, in a large study done by Mark Zimmerman, people who got their diagnosis of BPD were no less satisfied than other patients who had other diagnoses. And the majority of patients report acceptance and interest in this. And this is true for adolescents too. The problem is the clinicians themselves are so phobic and have such internalized stigma about the diagnosis that there is a tremendous delay in delivering diagnostic disclosure. And on average, that delay was 15 years. The symptoms of BPD are quite obvious. The distinguishing features are the interpersonal ones. These are the ones that create a lot of instability in the treatment alliance and a lot of countertransference that is difficult for clinical professionals to manage. Now, we think in GPM, this is the core, so does MBT and TFP. And this, combined with emotional dysregulation that DBT centralizes as the core engine of BPD, creates hyperarousal in the neurocognitive system and impairs cognitive control. Now, even when you just break down these 3 components of neuropsychological functioning, it gives you 3 locations in which interventions can be applied. And if we talk about managing interpersonal hypersensitivity, emotional regulation, and cognitive control, that may help us better address problems of self-endangering behaviors that are usually the signal that get us involved. Now, with this degree of instability comes this lack of cognitive control that not only is isolated to impulsive self-endangering behaviors, but also contributes to paranoia and dissociation. And taken together, The problems of identity form when one finds themselves so unpredictable and unreliable. They feel lost, confused about who they are, what they want, and other people find them confusing. Now, this is a coherent narrative that you can tell people so that they can make sense of their experience. GPM has another kind of healing myth, a way of understanding the oscillation of symptoms that really centralizes interpersonal hypersensitivity as a core problem. And it goes like this. It really centralizes a problem of intolerance of aloneness that John Gunderson said was characteristic of BPD in 1996. And it's this insecurity, because one can't rely on themselves, that they are most stabilized when connected to another important person. But even when they are kind of relatively compensated in a stable relationship, they remain rejection sensitive. They will be receptive to collaboration to cope and be invested in life, but they are dependent, insecure, and vigilant, seeking cues of something that may threaten that relationship that they're relying on. And whatever disappoints this idealized notion of what that relationship needs to be to feel stable sends that person into fight or flight. This is a threatened response. It includes the devaluation of others, fighting, blaming, etc., as well as kind of turning that aggression or anger inward in terms of self-criticism and self-harm. Now, this behavior of fight or flight pushes other people away. So even if there wasn't a real threat to that relationship, there is because of this behavioral response. And this is what leaves patients more seriously alone. And when they're unanchored from a stabilizing, containing relationship, they become unanchored from reality, and they don't appreciate the future consequences, the realistic intentions of others, and the kind of reality of their experience. This translates into impulsivity, dissociation, and paranoia. And oftentimes, it's at this stage that patients become unreachable and they sink into a position of despair where they're more seriously suicidal rather than just self-harming, with this kind of hopeless sense that without others, they are worthless and they'd rather die than live. It's this signal on the lower set of states that invokes a unilateral intervention from others to rescue, confront, or contain. And this may bring the person back to a position of stability because they're more connected or they're more threatened. But those two states are more workable. Sorry for the reverse. And this actually stabilizes people. That's why people with BPD may become hospitalized and seem more stabilized by that because they're contained. And that's where I would can be done to intervene and address the problems of BPD. Because when someone's more connected or even threatened, their neurocognitive and emotional processing capacity is greater than when they are acting recklessly and in suicidal despair, when they make contact with a lot of professionals in acute settings, and their sense of agency and ability to face their life problems is improved. So keeping them in a state where they're either connected or threatened and working with their problems of BPD in those states can be quite constructive. But unfortunately, we generally wait until they're alone and despairing to try to do so when they are most unreachable. I'm going to skip this alternative model just in the interest of time, but that's another way you can talk to people about their problems of BPD. While people are born with a lot of vulnerabilities that contribute to the risk of developing BPD, BPD symptoms are normative in the development that people go through in their adolescence. Some people say all teenagers are a bit borderline, and in a way that's true, in the sense that BPD symptoms normatively increase between the ages of 9 and 14. But for most people, as they become socialized into the world of having adults be less kind of supervising and peers being more important, they tend to decrease as they consolidate their identities and their relationship to others. But some people have a higher loading of these BPD symptoms, which in and of themselves interfere with that socialization process. And those individuals stay high in the level of BPD they express, and they can be identified earlier, and interventions can be applied so that the distance from their peers and the kind of exclusion from developmental socializing processes can still be preserved. So early intervention is important. Because it's not just trauma that drives the risk for BPD, it's that people are born with negative temperaments biologically in a way that make them express difficulties that are oftentimes met with harsh punishment and low warmth. In fact, in a longitudinal prospective study of a representative sample of female youths, they found that these symptoms in a preceding time period predicted parental adverse behavior more consistently than the parental behavior predicted the BPD symptoms, except at the age 15, which it was bidirectional. This same finding was found in the UK at a younger age with dysregulated behaviors at early childhood, 4 to 8, predicting the likelihood of bullying and maladaptive parenting that then escalate the risk for BPD. But once someone becomes an adult, the prognosis is in some ways good because about 80% of people will remit from meeting criteria for BPD over 10 years' time. The problem, though, because they miss that window of socialization and gaining social, emotional, academic, and other sorts of capacities to be in the world, their functioning doesn't change that much. Even with some of these treatments, DBT was shown to result in remission of BPD symptoms in that McMain sample, but still that sample remained largely unemployed and disabled. It was the same for GPM. Now, after this McMain trial, John manualized for mass production the general psychiatric management arm into good psychiatric management, which is in this red handbook. And it really took an initiative to improve focus on functioning as a mainstay of the treatment. And you'll see in the 6 principles listed here that change is expected in GPM's approach, even though it will be challenging. And the patient is held accountable to work on their problems of BPD and increase their functioning based on what we know about the trajectory of BPD over time. If we think about the naturalistic course of BPD, that most people will achieve remission, we can have some optimism and then focus on their capacity to work, be self-sufficient, rely on themselves so that their relationships can become more stable. And this is true and can be applicable in inpatient workflows. The GPM approach is something that can be incorporated at almost any level of care. And this is an inpatient workflow that's just standard, starting with diagnostic assessment, providing some structure and activity, and aftercare planning that addresses the reasons for the admission. So what you're generally trying to do is just help people to do these things, which are good psychiatric management for people in general. Thinking first, increasing cognitive control in the face of interpersonal hypersensitivity, high arousal, and emotional dysregulation. Get out in the world and do things pro-socially and effectively to develop a corrective experience of oneself as capable and a more realistic notion of other people and what you can rely on in them. And lastly, getting a life to be functional, because having a life and doing things that are important to you are the social capital that will fuel more satisfying relationships. Now, in the very last bit, and I'll stop after the psychopharm, is what not to do for the treatment of BPD, and that is not prescribing a lot of medications for the disorder. There are few inadequately powered RCTs for BPD. No drug is licensed by any regulatory agency, and yet most people with BPD are on at least one medication, and 20% of people with BPD are on polypharmacy. Now, when we did the APA guidelines, based on this paper done by the same group at the RTI, we changed the approach to not use meta-analytic studies to target domain-related symptoms like affective instability or impulsivity, because that's not actually proven in randomized controlled trials. So we looked at the literature. There was a high risk of bias and low certainty, and these were very short trials with few participants. And the punchline is that there's no medication class that reduced BPD symptom severity, low certainty that anticonvulsants work to improve anger, aggression, and affective lability, and second-generation antipsychotics improve general symptoms, not BPD. No medication improves functioning. And I'm going to skip to the end, but the one thing about benzodiazepines is that they are disinhibiting. And in a study, which I'll show you here, this study that was done in Sweden, they looked at prescriptions in the real world of patients diagnosed with BPD in their medical record base, and they looked for hazard ratios associated with psychiatric hospitalization and death. And what they found was that if you look at these graphs on, if you can see my arrow, all of these classes of medications increase the risk for psychiatric hospitalization or death. Mood stabilizers were kind of neutral. And then the one medication class that improved the risk was ADHD medications. So I will skip the co-occurring section in the interest of time and just leave you on this note. So my major message is that you don't need to be a specialist or selflessly devoted to be good enough in providing effective care for these patients who have BPD. You just need to be warm, reliable, interested, and unintimidated by the characteristic symptoms that define the disorder. And you'll need to know some basics about case management. And I'll stop there.
Thank you so much, Dr. Choi-Kain. We have a few questions in the chat for the last few minutes. The first two I can combine. It sounds like there's a request if you can speak a little bit more towards addressing diagnosis and treatment in children and adolescents, and if the resources for assessment apply to the pediatric population as well.
Yeah, so I did a book on GPM for adolescents with Carla Sharp, who's an international expert on the development of personality problems in adolescents, which is, as many people know who treat this population, a kind of critical period of emerging psychopathology that's poorly defined and poorly declared, but that could use some early intervention. And you're totally right that families need support. In the course of writing this book, she actually taught me that the diagnosis of BPD was always allowed since the DSM-3, which only had the qualifier that if you're diagnosing it before they age 18, they have to have the symptoms for a year, for which many patients will meet criteria. So now it's widely accepted that the diagnosis of BPD can be made much earlier, and there are many treatments that have been developing and in the process of being tested to better intervene for this population, because we know from the study I mentioned that MBT in groups actually isn't as effective for adolescents as it is for adults. But what is effective is providing some psychoeducation as BPD is emerging, talking about interpersonal hypersensitivity and emotion regulation. There are no negative side effects to teaching young people and their families how to better manage that, so that young people with these emerging symptoms can learn to manage them better, know what to expect, and customize their home and academic environment so that they can stay in the game of their developmental process. What happens instead is that we avoid diagnosing things, we don't treat them assertively or actively, and then these patients remain in the socialization of the hospital system, or dropping out of life and having school non-attendance. And that's not necessarily a better outcome. So what we're encouraging professionals to think about is, what are the options to diagnosing BPD if you're not going to do that? If you don't diagnose BPD, people are left with a notion of themselves that they're bad students, bad sons or daughters, bad kids with behavioral problems. Nobody likes them. None of those attributions are less stigmatizing than BPD. And if you can deliver the BPD diagnosis without internalized stigma, saying this is a disorder that's treatable, it can get better, and you can learn socio-emotional skills that will make you more effective in the face of your vulnerabilities. Who wouldn't benefit from that? So that's my little plug for early intervention. In fact, Carl Fleischer, one of UCLA's past trainees and faculty, he is in this book, and it was written in collaboration with all child adolescent psychiatrists who have experience working with this population.
Thank you so much. And one last question. Could you briefly comment on common drugs to consider with the most evidence, and your thoughts on using that with BPD?
Okay. The easy answer is there are no medications for BPD. The thing is, a lot of people know benzos are not ideal. And the one slide I didn't get to really go over in detail is actually having personality disorder features makes it more likely, or is associated with a higher likelihood of more difficulty getting off benzos. That I learned from Peter Tyrer in the UK. So there is not only the disinhibiting effects of benzos, but also these are patients who are more likely to become attached to these medications and dependent. When it comes to any prescription, I cannot recommend anything on label because nothing's indicated. But oftentimes second generation antipsychotics are used to alleviate general psychopathology symptoms, general psychiatric symptoms that may be in the profile of patients who have BPD that present in acute settings. So these are low dose, short term. That's what the recommendations of the APA guidelines are. Those are up for vote in November. And if you Google it, you can find the draft of those guidelines online.
Thank you so much. Well, it has been great having you. Thanks for coming out in your East Coast time to present to us.
Thank you for the invitation, and enjoy your last week of August.